So I'll just allow Kapupa. Kapupa, are you connected? Just say hello to the network.
Yes, good morning. Thank you, Dr. Muhuma. Sorry, good afternoon. Thank you, Dr. Muhuma, and good afternoon to everybody. Thank you.
Thank you for joining us, Kapupa. I'm sure we'll have a lively discussion. We've heard from Dr. Wantula. Dr. Wantula, you can say good afternoon to the network.
Good afternoon, colleagues. Glad to be part of this very important topic and conversation. Thank you for having me. Thanks.
Thank you so much, Dr. Wantula. And so I just want to take this moment to do some reminders. Zoom etiquette, remember to mute your mics when you're not speaking. But we always give a platform. Whenever you want to make a contribution, you should be able to unmute and make your comment when we call your name, or you can use the chat box. As the presentation is going, obviously you can use the chat box to be able to just ask your question, make a contribution, and we'll get to it right after the didactic presentation. So the way the session is going to move today is we'll start off with a didactic presentation, and after that, if you note something that's very interesting, put it in the comment section or write it down, and we'll allow you to unmute later and you'll be able to speak. Also remember that if you're not in a good network area, or indeed if you're in a public place, you can switch off your video so that we reduce on the bandwidth use. Apart from that, just ensure that you enjoy the ride with us, and we'll ask Mr. Chimuka, are you ready to start the presentation? Okay, so Mr. Chimuka is ready, but with me in the hub, I'm joined by Prudence. She is our HSS nurse. So we'll allow Prudence to read to us the poll questions when they do come through. So I'll ask her to just quickly settle down, and then we'll allow her to do that. So without further ado, I'll ask that Mr. Chimuka does his introductions, and then we can start the presentation. Mr. Chimuka, over to you.
Okay, thank you, Doc. Like I've earlier been introduced, I'm Chimuka Sianyinda, Strategic Information Officer. I support HIV program with M&E. So we'll try to discuss issues pertaining to MCH and also SMARTCARE. So with regards to in terms of our learning objective this afternoon, we'll try and discuss in terms of the SMARTCARE coverage with regard to the utilization in our MCH. We'll also try to outline some of the challenges we have, and also we'll try and show, in case we do have some modules in SMARTCARE, which modules are there, and also describe the current updates in our MCH modules. So that's what we'll try and focus on this afternoon. So maybe we'll go to the poll so that we just see our level of understanding with issues of SMARTCARE utilization.
So, dear network, just kindly bear with us. Prudence, you can come and sit on this side. We're just setting up, and we'll launch the first poll question. We'll have Sister Prudence read it out to us. Then we will show her video just a little later. Prudence?
Okay, so our first poll question is, the SMARTCARE Legacy Plus Pro has the following modules in SMARTCARE. Is it A, ANC and ART plus family planning, or B, ANC, LDPNC, child health, ART, as well as FB, or C, only ART?
So we'll launch the first poll question and allow you, the listeners, as well as the participants, to just take part in this. The answers are coming in fast.
So I'll repeat the question. The question is, the SMARTCARE Legacy Plus Pro has the following modules in SMARTCARE. Is it A, ANC, ART, and family planning, or B, ANC, labor and delivery, postnatal care, child health, ART, and family planning, or C, ART only?
We have just over 65% that have poured in, and we've run this poll for about a minute. We'll end the poll here and share the results, and then we'll go to the next poll question. Mr. Chimuka, the majority think that B is the answer, but I'm sure the presentation will make it clear as we go. So we'll go straight to the next poll question. Poll question number 2 has been launched.
So for our question 2, the question reads, the utilization of SMARTCARE in MCH is above. The utilization of SMARTCARE in MCH is above. Is it A, above 70%, or B, between 69% to 30%, or C, below 29%? The utilization of SMARTCARE in MCH is above. Is it A, above 70%, or B, between 69% to 30%, or C, below 29%?
We'll give this poll just 10 more seconds. Very interesting question. We'll end the poll here having almost 70% participants polling, and we'll share the results. So from this poll, you can see that the majority, which is 49%, less than half, think that B is the answer. And we have 35% significant that think C is the answer. And we also have about 16%, which is A. They think above 70%. Thank you so much, Prudence. Thank you so much. We'll continue with the presentation. Mr. Chimuka, over to you.
Once more, Doc, again, thanks very much. Actually, it's very gratifying that the network, they have been able to state in our first poll that like those who answered a question on the first poll, those who answered B, they were correct. We have a number of modules in SMARTCARE. Again, when it came to utilization, again, almost half of them, they indicated that we are below 29%, which makes even our presentation this afternoon to be a bit easier, because we'll now be focusing more on demand creation to entice our network so that we understand and appreciate some of the reasons why we should be using SMARTCARE. But before we go into the nitty-gritties, we want to just understand with regard to the overview of Zambia's vision with regard to data collection system. You agree with me that as we have been moving, we want to be attaching a human face to the intervention we'll be able to make. So what the ministry and its implementing partners, what we try to envision to see that we want to have patient-leveled information system above site so that people will be able to make decision. And what the ministry would want to see is a scenario where when people go for HIV testing, for example, because HIV testing, as we all know, that it's a gateway to either getting treatment or getting preventative services. So should be able to,
Sorry about that. You can continue.
so the meaning.
Dear network, just a reminder that as the presentation is going, you just ensure that your microphone is muted so that we do not disturb the flow of the presentation. Thank you.
Okay. So I was just trying to explain to say that the ministry tries to envision that we should be able to collect patient-level information system above site, because this is able to give us a true cascade. And I was indicating that our entry point is HIV testing. When people test for HIV or they come for HIV testing, it's depending on the results they'll get, it's either they'll get treatment or they should be able to get preventative services. And when people are getting preventive services, we should be able to tell a story. These services we provided, how effective were they? These services our people were getting, how many actually were converted along the way? And this is the part where also PMCT falls in, because when mothers go for antenatal, first we want to rule out HIV amongst the pregnant and breastfeeding women. And for those who are HIV negative, there are a number of preventative services the program has put forth to ensure that we prevent mother-to-child transmission. Should a mother be HIV positive, there will be certain intervention we are going to put forth, or our clinicians and our midwives are able to do those interventions. And at the end of 24 months, we should be able to tell a story of those children who were HIV exposed, what were the outcome? What other factors would have put these children at a higher risk? Now, we can only be able to tell that story if we do have patient-leveled information system. So here I was just trying to explain in terms of our current data system. So for example, HTS, purely matters of HIV testing in our country is purely paper-based. It will be another day, we'll discuss that issue. But I know part of the PMCT falls under HTS, like I earlier mentioned, that for us to be able to test these pregnant women, we use the HTS module. But the point we're trying to showcase here is that we do have electronic system in Zambia. But as things stand now, HTS, like I indicated, that when clients come, the first service they're offered is HIV testing. And depending on the result, should the result be negative, we do offer HIV preventative services in our facilities. Should somebody test positive, we initiate them on ART. Now, as things stand today, when we look at our ART setup, over 95% of our clients who are receiving ART services actually are into our electronic system, which is SMARTCARE. But where we do have a challenge is when it comes to HIV testing itself and preventative services. These are mainly collected using paper-based system. Even when we do have electronic system in place, which is able to capture these data element, we are mainly, or as a country, we have mainly been using the paper-based, which has also its challenges, as we'll be able to discuss in a few minutes. So briefly, so I was just trying to say that our HTS is purely paper-based and above site, meaning the district, the provinces, and national level, the only data we have is what has been aggregated from the facility. So for example, if there are people who have tested positive, there are certain parameters I want to know about them. I won't be able to interrogate because the data we collect in our DHIS2 is aggregated. But at facility level, we do collect the data in form of paper. And again, the other challenge, like I mentioned, that for those who test for HIV and have been linked to preventative services, or have been linked to treatment, it becomes difficult for us to be able to say, person A whom we tested here, actually the same person who is getting services in ART, the same person who is getting preventive services in these other services. Equally, when it comes to preventative services, where even our PMCT we are discussing falls under, mainly matters pertaining to mother-to-child, the prevention of mother-to-child transmission, be it in ANC, labor and delivery, postnatal services, immunization, and also the baby mother follow-up services. We are mainly relying on paper. But when it comes to ART, and the good part is that we already have a model, which is ART, which is working very well in our country. A number, like I already indicated, a number of our facilities, when it comes to ART, they are using SMARTCARE, and the numbers we're able to report on actually are coming from SMARTCARE. Now, before we proceed, I wanted to pose certain questions to the network. I know today is the 28th. Maybe somebody can be able to get to somebody, if they can point at somebody who is not an in charge. If we can have somebody who can just somebody ask a question. I want to find out this week and next week, what is the most important thing which will be happening in our facility? Somebody just tell us, work-wise. It happens every month. It's very tedious. Who is able to tell us? Today is the 28th. Let me say most likely next week.
So we've got 2 hands here. In fact, 3 hands. We'll start with Rita. Rita, please unmute and go ahead.
Good afternoon, network. For next week, we'll be having data collection. Thank you.
Another one to tell us?
I can see Catherine Piri Kalabo. You can unmute.
It will be a reporting period since it's a month end.
Okay.
Okay.
Then, so we've also got, I think, one more. Danisiosi. I'm not sure how to pronounce this name.
Okay, thank you so much. We'll be having a monthly data collection.
How do you pronounce the name?
It's Danishas.
Danishas. Thank you.
So again, yes, it's a great thing. Next week, people will be doing the data collection. Again, another question I want to find out. I want this to be more of a practical of what's happening in our facility. So next week, when people will be doing the data collection, do the in-charge allow people to move out of the station? We know also the same week for month, is it per month? Yeah? What you call it? Like month end, we have been paid. For those from rural areas, that's the time people go for shopping. Again, I want to find out, do the in-charges allow us to leave our facility this next week? Like the time for reporting, especially those operating in MCH.
So we can start with Danishas. Danishas, you heard the question. Are you allowed to leave the facility? Or maybe you're an in charge yourself. Do you allow people to leave the facility during this time?
Definitely, we are not allowed to move because there will be collection of data from different departments, of which each and almost every representative from each department should be there so that a quality data can be collected.
Another question I wanted to find out, how is the data collection in MCH, specifically now MCH? Is it something easy? Is it something which is walkover? How has been the experience? We want other people to also to be able to comment.
So we can have hands from other people. Mwanga, please go ahead and mute and speak.
Okay, thank you very much. When it comes to MCH, it's not something which is very easy when it comes to data collection because it is paper-based. So meaning we are going to go page by page when it comes to antenatal register, checking with the names when it comes to people who came for first antenatal visit, those who came for second antenatal visit, and so on. So it's something that needs group work, and it's not easy to do it alone. Thank you very much.
We've also got Paula. Paula, I think this is Paula from Chawama, level 1. Paula, you can go ahead and unmute.
Thank you. Good afternoon, Dr. Muhuma.
Please go ahead.
Yes, so just to concur with the previous submission, because you have to go through registers and count one by one, it is not easy, in the sense that we leave it as the last thing to be done in the day. So you see the patients first in the morning, then in the afternoon you come to count. So sometimes data can be compromised when you do it because you are tired at the end of the day.
Thank you so much.
And then not everyone is keen on coming on board to do that. They only want to come and collect. Sometimes, depending on who is assigned to come and collect the information, the data. But when you sit and do it together, it becomes easier. In case you make a mistake, you have a correction from your friend. I submit.
Thank you so much.
So another question, Doc. This one now got, especially I'm happy that Chawama, the high volume, actually participating. So this one, the next question I want to ask is dedicated for high volume sites like Chawama and Matero and the others. But how is it in the same period? How is it to report, or how is it those in ART when it comes to reporting? Do they struggle?
I think we can also get views from even other provinces.
Yes.
Anyone from Eastern Province?
Kapata is there. If Kapata is there, preferably Kapata if it's there.
Anyone from Kapata? If we don't have anyone from Kapata, do we have any high volume in Western Province?
Mlambwa should be one of them. Lewanika, Mlambwa.
Anyone from Western Province that would like to give that one a try? How easy is it? Vanji, Chilombe. Unmute. Vanji, your hand is up. You can unmute.
Okay, thank you so much. I think in terms of data collection in ART, since we are using SMARTCARE, data collection is very easy because there you just print out the report you need. I think there is no problem in terms of data collection. For as long as you are imputing the correct data you need, then even correction, just a matter of printing out the report you need. Thank you.
So Vanji has given an answer and has put a caveat to it. As long as you're inputting the correct things, you should be able to get out the correct things. Go ahead, please.
Okay, so deliberately, what I was trying to do, network, was I was trying to indirect to try and demonstrate one system in our facility where we use purely paper-based system and another system where we use electronic system. And I tried to touch on the aspect of people going for payday, and our vigilant in-charges are always there to ensure that people do not leave the facility and ensure that they first do the data collection, especially for MCH. And I know a number of us who are joined here, I think that's one area we normally have difficulties with our in-charges because we are grounded. And our colleagues in ART, they may seem to be favored a bit because for them, by next week, Monday, if the month has ended, they have entered the data in their system. When it comes to reports, it's just by the click of a button, the numbers are there and they fill in on the HIA tool. If it's MER report, they fill in and off. If they want to go for to the town to go and get paid and do shopping, they would leave. But a number of us especially us in MCH, like somebody earlier indicated that, for example, if you want to report on if it's a subsequent HIV test, I have to flip pages. Sometimes you'll find if it's antenatal initial visit, you find you would have filled in on that activity form which has gone missing. And when month end comes, because they can't find that copy. So what are we trying to communicate here? What you're trying to say is that there are a lot of advantages of us using electronic system. I first pointed out advantages to us as healthcare workers because, especially for those from high volume sites, the first week of a month is a bit hectic. For them, sometimes it even affects the relationship at home because this woman will be coming home very tired. The mood will change for that week because she has to count from page to page. So you find it's a very tiresome process. But we do have an easier way, which both the ministry itself and the implementing partners, which they are pushing for, at the same time, it works to our advantage. So all what we are trying to demonstrate, network, is that the moment we start using electronic system, it does not just help yourselves, it also helps this, the system. So you would find that there are a number of data elements. For example, I've just beamed part of the indicators we're supposed to report on. Now, if we continue using paper-based, one, like I already indicated, that we want to ensure that because when it comes to the interventions the government put in, whenever there will be change in intervention, it's dependent on, it will depend on the data we have produced. At the same time, government is alive to the fact that people also should ensure that they have a breather. So in our SMARTCARE, we do have, or in our electronic system, which is SMARTCARE, like you correctly, we had correctly indicated that we have a number of modules, not only limited to ART. We also have got ANC module, labor and delivery module, PNC. We even have child health, even immunization. As you'll be able to see as we go along, we're able to show you that we can even do those plotting of the under 5 card in our MCH module. And once the data is in our electronic system, when it comes to reporting, which is a big problem for most of us, because that week, like you have agreed with me, that a number of us, we are not even allowed to move out of the facility. But if you are to use the electronic system, it will become easier, like our colleagues in ART, because for them, the data is, the report is just by the click of a button, we are able to have our data. Now, I just wanted to remind you that for our, in MCH, our aim is to be able to eliminate mother-to-child transmission. And there are quite a number of indicators we are tracking. We have the process indicators, which deals with matters pertaining to antenatal coverage, mothers testing for HIV, matters pertaining to HIV positive pregnant and breastfeeding women who are on treatment, and also matters pertaining to children who are HIV exposed, and we are tracking them, and also women who are HIV negative postpartum period, but they are breastfeeding and want to track them, to test them and ensure that the time when they are breastfeeding, they are not at a risk of transmitting HIV. Now, when it comes to a number of these data elements we have shown, it is a bit cumbersome for us to have these reports. And remember, the other challenge paper brings in is the issue of the quality of data. The poor the data quality, it also borders on issues of not only just testing kits. I know even a number of us, sometimes we do complain that sometimes the testing kits we are given are limited. Sometimes these issues of limited testing kits come as a result of what you would have reported. So sometimes you find, depending on our system, especially when you're using paper-based, some papers will go missing. And when it comes to quantifying, we quantify on what you could have reported to us. You may not see at that point that the inadequate testing kits you received, the not testing kits you received came as a result of, because of that paper, you documented, but it went missing. And by the end of the month, when you're aggregating, that paper was missing. And when the national team sits to quantify for your drugs, when the national team sits to quantify for your testing kits, we may end up under quantifying because of the data you had given us. So you would see that there are a number of indicators we want to track, like the matter I was talking about. These are issues pertaining to issues of case rates, the process indicators. All these data elements, it means that somebody has to sit down. You have to start flipping the pages of the mothers who came for antenatal. For example, if today we are likely to have mothers who are attending antenatal, for example, maybe those who are 8 months pregnant, assuming they started attending antenatal when the pregnancy was about 16 weeks. So it means when mothers come for antenatal, because they would have booked in different months, it means that mother or that healthcare worker has to flip, I don't know how many pages, to just count the number of people who came for antenatal, who tested for the subsequent test in that month. Again, you see that we have a number of indicators we are tracking. So all what we are trying to say is that as things stand now, if we exclude ART services, if we are talking of antenatal services, labor and delivery, postnatal services, less than even 5% of our mothers are in SMARTCARE. Only ART, that's where we seem to be doing fine. But these other services, which are very critical for decision-making, mostly they are paper-based. The program, for example, would want to know if children seroconvert, because of the data we collect is aggregated, we are unable to tell, for example, to say, oh, these children who have seroconverted, what type of mother are they coming from? Is it the non-positive? If it's a non-positive, is it the non-positive who are already on treatment or they're not on treatment? Is it the woman who tested positive and entered and refused treatment? Or is it the woman who was on treatment? So in short, there are a number of information the district, the province, and the national level would want to know about these children who would have seroconverted. But because we do not have data in SMARTCARE, even when people are having the DIM, much of our time when it comes to making decisions or attributing to the factors contributing to these children who would have seroconverted, we always say, we think, because we do not have the data at national level. So there is need for us to ensure that we change and start moving towards collecting this data for us to be able, one, at national level, for us to be able to make policies aimed at addressing the issues. For example, I'm just assuming, we may find that, for now we may not know, but we may find that, for example, that of the children who are seroconverted, actually it's those children whose mothers were non-positive, but were not on treatment. If we are going to have data which will show us that, for example, more than 30% of the children who are seroconverted are coming from such type of mothers, then it will become easier for government to come up with intervention aimed at ensuring that women who are HIV are positive, women attending family planning, for example, or these other services, they are put on treatment because we would have known where these children are coming from. Or we may find that the children actually seroconverting are those children whose mothers actually were diagnosed to be HIV positive during postpartum period. It becomes also easier at that point for government to come up with intervention so that we help out in ensuring that we eliminate mother-to-child transmission. So, like we already indicated in our poll, our SMARTCARE do collect data pertaining to antenatal services. We do have, in short, we do have the ANC module in SMARTCARE. We do have the labor and delivery module in SMARTCARE. We do have the PNC. And you agree with me, just the good part that we do have our ART, which is able to demonstrate. Even when it comes to the EMR report, when it comes to HIL2 reports, our SMARTCARE, I know our colleagues in IHM, they're working around the clock to ensure that the reports are always in tandem with what is obtaining on the ground. But the bottom is, for you, your role is to ensure that you do your part. The part IHM should be able to do its reports, they will also be able to do their part. But for us, our appeal is that, one, should we start using SMARTCARE? One of the advantages it will bring to the table is that it will bring efficiency, because when it comes to reports, at that point, if everyone is trained to do a report, even the in charge will be able to just go and click and be able to produce the report. The issue of the travel embargo we go through in our various facilities, especially us coming from same rural areas, it will go because anyone can go and be able to click the way it's happening in our in ART. So let's just have a look at some of the modules we're able to collect in SMARTCARE. So like I earlier indicated that we do have the antenatal services module. So in short, this module, we try and be able to get data pertaining to the ANC initial visit, as we know that we want to know the women who are attending antenatal for the first time. We are also able to capture ANC follow-up visit. So what you're trying to say here, just like the way the antenatal register is structured, that when a woman comes for antenatal for the first time, the initial visit, there are a number of services these women are subjected to. Some of them are screening, some of them are supplementation of supplements, HIV testing, and these others. So in the ANC initial visit, though the same way the antenatal register looks like, the mother will be able to document the services a woman could have received. Should the woman come for antenatal follow-up visit again, or the one we call them subsequent visit, again, the services a woman would have received will be able to document. Matters pertaining to ART services, again, will also be able to be taken care of in this module. And when it comes to report, it will be automatic for us to be able to produce these reports. In M&D, we say, in God we trust. In any other thing, please bring evidence on the table so that people can see. So what I'm trying to say is that this is just more of what you may find when you go into our SMARTCARE and want to go to the MCH module. These are some of the modules you'll be able now to click and be able to offer a service to our mothers who are pregnant. The other service which is also offered is the labor and delivery. So women, when they go to deliver, again, we all know that there are also aspects of PMTC services which are also offered. Not only just PMTC services, just matters pertaining to reproductive health services, the pathograph, or other things which are done, the delivery, discharge, all those things actually are also, you will find them in the labor and delivery. So in short, the MCH module, the labor and delivery, and the other modules you'll be able to discuss are not only focusing on HIV related, but they are designed to offer a wide range of services which are offered in MCH. So meaning, it won't just be about the HIV services, but even these other non-HIV services, your report will also be able to be ready as soon as you are done with data entry, and if it's a time for you to report, it will now become easier for us to be able to report. Again, this is how our labor and delivery module looks like. Those are some of the modules, the sub-modules you're able to find. There's labor and delivery, PMCT, the summary, discharge, and also the pathograph. Again, this is just PMT, this is postnatal. So what we did was we did not get everything, but we just wanted to showcase some of the modules you are going to find in our SMARTCARE pertaining to also maternal health, but also just in general, the modules you are going to find. So we also have got issues of postnatal services. Again, you're going to find, so you see there is postnatal, specifically for postnatal services, but there's also postnatal PMTCT. These are services pertaining to PMTCT services. We do also have child health, the child health module. Again, the issues of nutrition, TB review, and a number of services actually which are also, when it comes to complaints, we also have got pediatric history, examination, and a range of services. And not only that, even when these children come, when we weigh them, the system is able to plot for you and will be able to monitor how this child actually is performing. Equally, not only just about weighing, growth monitoring, and promotion, we also do. We do also have matters pertaining to vaccination again. Like I earlier mentioned, that the child health service is not just about HIV, but there is a range of services which are offered. Growth monitoring and promotion, vaccination, and these others. So you can see, like I earlier shown, that these are some of the modules actually we do find in our SMARTCARE pertaining to MCH. Now, as we go towards the end of the presentation, some of the things we just want to remind ourselves is that the Ministry of Health, like I earlier indicated, the Ministry of Health, together with its implementing partners, they wish to collect patient-level information through an electronic system. I earlier emphasized that we want to ensure that even above site, yes, there will be no names, but we should be able to attach, and when I say a face, as in this is the client or this is the patient. These are the services this child received. These are the services this woman received. It will become easier for one to even do various cascades of the women who are attending antenatal. How many actually are being tested? How many were not tested? Of those who were tested, how many actually were negative? Of those who were negative, for example, there's one issue the ministry and its implementing partners are working on, especially when it comes to issues of PrEP in ANC or PrEP in pregnant women. So you will find that it becomes a bit tricky to be able to tell of the women who tested negative, actually how many people are at a higher risk. Of those, how many actually are getting PrEP. As things stand now, when you go in our DHIS2, for example, what we're just able to get is that how many women tested negative and how many actually got PrEP. But sometimes we may have one or two women who are not at a very high risk or who don't wish to get PrEP. We are unable to tell a story. How is the PrEP in pregnant or in ANC, for example, being done? Are we on track? Because the data we have is crude data. We only have got those who are getting PrEP and those who are negative. But there may be other critical information we may want to know about these women who tested negative. But if we had SMARTCARE data, it will become easier for us to be able to tell a story. And like we all agreed, our network, that collecting data in an electronic system, it makes it easier for us to be able to report. We have had a case put forth, and we have had comparison of the paper-based in ANC and the paper-based, which is also in ANC for ART. You would find that for ART, when it comes to reports, it's just the click of a button. And again, the most critical part we should remember is that for the Ministry of Health, for us to be able to make certain policies, it becomes easier when people have above site information, where they have a lot of information pertaining to what is obtaining on the ground about our clients. So it becomes easier, one, for policy change. I'll give an example. For those who may be familiar with the implementation of the Kabele, because we are using an electronic system outside, just an electronic system in the DHIS2 tracker, there has been a lot of policy changes which has taken place in a short period of time, because the facilities which are currently implementing the PrEP, we are collecting patient-level information system. And when we have been faced with a challenge, it has been easier for the leadership, both the ministry and its cooperating partners and implementing partners, to make a decision about a policy change, because we do have patient-level information above site. I may not, it's not a discussion of vocabulary, but those who agree with me that we have seen there's been a policy change even when it comes to the actual testing. Equally, we are just trying to emphasize that when we collect data on patient-level information, especially on matters of mother-to-child transmission, we're trying to prevent or eliminate mother-to-child transmission. Issues of having patient-level information above site is very critical for prompt and also for sound policy decision. I think for now I'll end here and I'll allow our colleagues to be able to chip in one or two things I submit.
Thank you so much, Mr. Chimuka. This has been a really good presentation, and the participation, I can see we are over 460 participants already. We had reached almost 500. Very good. I can see there's a lot of interest in this topic, and we want to spend some time doing discussions for this. The chat box has been very busy. Dr. Sam Msariri has also been busy responding to some of the questions. But of course, all the participants are going to weigh in. What are some of the challenges that have been there, especially with SMARTCARE in MCH? And what are some of the workarounds? Those are some of the things I think we will want to discuss, because even in the chat box, a lot of issues that have
Yeah. Yeah.
Sorry about that. So I think before we get into the discussion, before we read out from the chat box, we invite people to weigh in. I want us to do a repo questions. So what we'll do is we're going to repo and just to see if learning has taken place. We have Prudence Mulambia. She's a health system strengthening nurse based at Matero with the Lusaka Provincial Health Office. She's going to read to us the questions. So we'll relaunch the questions and then we can be able to repo. So the first question will be launched. Prudence, you can take it away.
Okay. So our first question is, the SMARTCARE Legacy Plus Pro has the following modules in SMARTCARE. The SMARTCARE Legacy Plus Pro has the following modules in SMARTCARE. Is it A, antenatal care services, or ART plus family planning, or B, antenatal care, labor and delivery, postnatal care, child health, ART and family planning, or C, only ART?
Thank you so much. We have done almost a minute. We encourage the participants to poll. We've got such a huge number of participants. So some facilities are still using legacy, others are still using Plus, and more recently we're also using SMARTCARE Pro. So for those that have had the privilege to interact with the systems, which modules have you seen in SMARTCARE? Is it A? Is it your ANC and ART, as well as family planning? Or is it B? It's got the ANC, labor and delivery, PNC, child health, ART, family planning, or is it only ART? We will end the poll here and share the results. So, Mr. Chimuka, the majority think that B is the answer, 95%.
Yes.
There's a very small minority that think A is the answer. You can speak to us about this question.
Yeah. So like we indicated that because I know sometimes, Doc, it's the issue of perception. Sometimes it's what people could have heard. I know when it comes to ART, even when it comes to MCH itself, mothers who are on treatment, our healthcare workers, our nurses, they use the ART forms and they're able to send to either data room or themselves able to enter. So when it comes to ART seem to be popular in MCH. But when it comes to these other services, I think we have not done much as the ministry and also as the people from the facilities. I think this is also the reason why such discussion have been brought forward for us to be able to sensitize ourselves and remind ourselves that in smart care, it's not just actually ART which is there. A range of these services actually are there. That's why we are also able to even showcase that even a pathograph itself, on a lighter note, the one most midwives are trained from the same institution, they always tell you, why haven't you done it? They will say, the woman was fully dilated, that's why we didn't open it. Anyway, but even the pathograph itself, you'll find it's there in our smart care. So what we're just trying to...
Messi, how are you?
What we're trying to demonstrate is that these modules pertaining to MCH, they are there in our MCH modules. And the discussion maybe we should now be having are things like how best can we make it easier for us to be able to, I know we have attempted, Doc, and the other didn't talk about much that one. There's one where we attempted to merge the ART for the mothers and also the HIV exposed infant. There have been some discussion, I think at an appropriate time, I think to be discussed where we want people to be entering data like they will do it in ART, where this midwife will be able to have this form. When a child comes for EID services, we're able to tick or tally or indicate what services they have provided. And if they're unable to enter, they give our colleagues in ART for them to be entered for them. So I think the discussion now we should be having is how best we can be able to strengthen the smart care modules. But what should come first is for one to be able to demonstrate that actually we're entering this data. But the challenge we are having are challenge 1, 2, and 3. How best can MoH and IHM be able to actually help us? But as things stand now, a number of us, we do not actually, we rely more on paper. I should also make mention, maybe something again I forgot to mention, that even when we check in our guidelines, when it comes to M&D, when it comes to HIV, our HIV Zambia consulted guidelines, module 10 or module 10, it clearly indicates that where we have paper-based system and electronic system in one facility, the electronic system takes precedence. So meaning we should not have a scenario where on one hand you're entering data in a register, on the other hand you're entering data on the, in smart care. We should have one system only when, for example, like now, in case I've got issues of power outages at a particular point in time, that's when you can use the paper-based system and then revert back to the electronic system. I submit.
Thank you so much. And yeah, and I think most people in the chat box have raised this concern, and we'll be able to give Dr. Sam and other IHM colleagues the platform so that they can be able to speak about some of the things that have been raised. We'll go to poll question number 2, which will be read by Prudence. Prudence.
Okay, so our second poll question states, the utilization of smart care in MCH is above. The utilization of smart care in MCH is above. Is it A, above 70%, or B, between 69% to 30%, or C, below 29%? The utilization of smart care in MCH is about which percentage? Is it above 70%, or B, between 69 to 30%, or C, below 29%?
Thank you so much, Prudence. As you can see, we had some typos in the question. it should say what the utilization of SMARTCARE in MCH is about what. Is it, is it above 70%, or is it between 30 to 69%, or indeed below 29%? So kindly use the poll box on your screens as opposed to using the chat box to answer the question. Look at your screens. You should be able to see this question on your screen, and you should be able to choose the answer that you want to choose. So we have a number of colleagues that are using the chat box. Just a reminder that you can indeed just pour on the question so that we can capture the data. The utilization of SMARTCARE in MCH is about, is it above 70%? Or is it between 30 and 69%? Or indeed, is it below 29% utilization of SMARTCARE in MCH? We will end the poll here and discuss the results. In fact, Mr. Chimuka, it's changed quite a bit. Before, most people thought, say 49% thought that B was the answer. But you can see 55% think that it's below 29% in terms of utilization. We still have some that think 30 to 69% is the answer, and about 7% think that A, above 70% is the answer. And I hope, I mean, I guess colleagues are answering based on where they are.
Yes, but also, also they should also think of not just ART, but you're also talking of ANC, especially don't you agree with me that when we look at our ANC, the MCH, for those on treatment, for example, like at national level, not more than 50,000. But those who are accessing ANC, for example, we have over 700,000 women accessing antenatal services. So you will find that a number of, especially those who are accessing antenatal services, there are very few facilities in our country where they are able to document our services in our SMARTCARE. Most of us, I would say probably, we are trying to be a bit, we didn't want to depress people by saying less than 5% or less than 2%. That's why I just said 0 to 9, to just give people that, okay, we don't want to, but if we are to go strict, we are even below 5%. Those who are our mothers who are in antenatal, who are in MCH services. Because even when it comes to family planning itself also, we are also able to capture, it's part of MCH, because we are able, and also the other reason we want to strengthen SMARTCARE. I think there's been this discussion that for us to be able to provide quite services in MCH, I stand to be corrected the numbers, but it was somewhere above 20 registers, though, which are needed in ANC. Now, the challenge it brings is that you'll find there are certain repetitive data elements which you find in all these registers. So this is one nurse who is found in Sinazeze, or who is found in Matipa Royal Center in Chilubi. She's alone. When she sees this woman, she has to indicate the name, where this woman stays, her age, next of kin, blah, 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 all these. It's the same information she's supposed to indicate in the HIV register. It's the same information she's supposed to indicate about this woman in family plan. So you find that there is a lot of repetitive when we use paper-based. But if this woman would have already entered certain parameters about her, when she comes for another service, we'll just focus on the services that we provided, because the other critical information which do not change would have already captured in our SMARTCARE. So the other aspect we are trying and see is how best can we reduce our workload? Because as things stand now, especially when people are using paper, people may spend the half of the month just documenting and reporting, and we may end up having only half of the month, except for high volume sites where we also have, we are faced with the challenge of human resource. So that's why we are saying, let's ensure that we start and improving our utilization of our SMARTCARE. Like you corrected, indicate that our discussion should be how best can we be able to ensure that also SMARTCARE on the other hand is also user-friendly. But for now, let's demonstrate the use of SMARTCARE. I submit.
Thank you so much, Mr. Chimuka. And I think at this point, I actually want to invite colleagues who want to lend a voice to this discussion. You know, we've had quite a number of comments in the chat box. I can see Apostle Max from Dola is an HNP. We've got Gracious, we've got Raston, Wambo, Shianda. Quite a number of colleagues have, said quite a number of things. Jinyama from Chama, DHO. There are quite a number of comments that have come through. And so I think at this point, we will allow, if anybody wants to speak, has a comment before our experts weigh in. If you have a comment, you have a question, you can raise your hand or you can put it in the chat box. But for now, we have quite a number of things in the chat box that we will go to. We'll just read out some of them, and then we can get some answers from either our experts or some of the colleagues on the call. So I think one of the first things I saw is from Apostle Max. He said SMARTCARE is good, but the problem is it's just in facilities that are in urban places. Really just, in and not in health centers. So the question is, when are you bringing it down to health centers and health posts? This is a question from one of the HNPs working in Dola. This one, I know that Dr. Sam, you'll be able to take that one. Then we have Proxon just says every new system has its challenges, but we need to include it as a must training for all health workers. Then, do MCH departments have enough laptops to utilize SMARTCARE? How about capacity building in SMARTCARE? Has it been done across the country? How many have been trained? So, Dr. Sam, are you able to just unmute, speak to some of the concerns that were raised in the chat box? Please start off with just answering the Apostle's question, Apostle Max, the HNP from Dola.
Thank you, Dr. Muhuma. Please just confirm if you can hear me.
We can hear you, Dr. Sam. Please go ahead.
All right. Okay, thank you so much. So allow me to write on the protocols already established and observed. And thank you once again for the invitation. I should mention that the work that IHM does is principally to support the government and the Ministry of Health. So I will be speaking really from that perspective. SMARTCARE is a product owned by the ministry and the government of Zambia, and we are simply supporting that implementation. So to start maybe with the first question regarding the facility in Dola that doesn't have SMARTCARE. If the person, I believe that was Apostle, if they maybe could just share their details with me. We did do a saturation exercise for Southern Province, Lusaka, and Copper Belt, where the goal was to ensure that all facilities were covered with SMARTCARE. So maybe if I could get his details, then we can make a follow-up just to find out exactly the facility, and then we'll be able to give him a response before the end of this week. I don't know if there's another question, Dr. Muhuma, you wanted me to respond to?
So I think some of the other questions I can see Dr. Jackson Shower has asked, maybe you can address, there are fewer laptops and other electronic devices in all the departments. How are we working around that as the Ministry of Health, as well as the rolling out? Then also just maybe connectivity issues. Did you get that?
Yes, I got that. So, okay, so that question I believe is coming from Dr. Johnson Shaw. Okay, so Dr. Shaw, maybe if you could just also mention the facility you're coming from, but just to give you the approach that the ministry uses when implementing SMARTCARE is first to do an assessment of the facility, find out the service stations that are in a particular facility, and then obviously map out the number of devices that will be required. You're right, in some instances, the devices are not adequate to cover all service points, but that's part of the work, again, that we're doing currently to ensure that we deploy as many devices into other service areas. So maybe if you could just share the details of your facility. But generally speaking, we do ensure that we cover them, the high volume service areas. So this range starts from registration to OPD, MCH, ART, pharmacy, lab, IPD as well. Those are usually covered with sufficient devices. But again, for me to just respond specifically to your facility, if you could share your contact details on your facility, then we'll be able to give you a response as well before end of week.
So thank you so much, Dr. Sam. I've seen 2 hands, and I'll give you a chance, actually 3 hands now. Chimwemwe, I've seen your hand. Kanyanta, I've seen your hand. But I wanted maybe Kapupa from the Lusaka Provincial Health Office. Are you able to weigh in on how we are working around power issues, connectivity issues?
Okay, thank you for that, Doctor. I think I'll touch on a few points, and I hope that during the course of me touching on those few points, I first and foremost respond to your question, and then I think I'll also sort of touch on some of the questions that may have popped up in the chat box that I may be able to respond to. So in my response, I'll begin by stating that we need to be very careful, and we also need to be very clear, especially when we begin to discuss, based off our experience as Lusaka province, we need to be very careful and very clear with regards to discussions around SMARTCARE utilization. I feel even as we engage in this discussion, we need to first and foremost define what we mean when we talk about SMARTCARE utilization. Because I would like to assume like right now, we have a participation of over 400 people. I think each individual's perception of utilization, I can guarantee if we engage the 400 would be different. For instance, certain people or certain healthcare workers would classify SMARTCARE utilization as them simply being able to log into the SMARTCARE system, enter data into the SMARTCARE system. A different cadre, let's say, or be more categorical, let's say somebody from the M&E department would take that definition a step further. Before I break down the definition, for instance, that an M&E cadre would give, I'll give you a very basic example of a mobile phone. A mobile phone is intended to make phone calls. So if I have a mobile phone and I'm able to save numbers in my mobile phone, but then this phone has been given an extra feature by the mobile service provider, which is what? It enables me to make calls that go outside. So therefore, I'll have a contact list and I'll have 100 contacts in my contact list. Me being able to save those contacts in my contact list, depending on who's utilizing the phone, they'll say that utilization is at 100% because I'm able to capture contacts. Another cadre who works in the service industry and needs to make phone calls and contact those people on the contact list and has that feature disabled on the gadget and is unable to make calls outside of that phone, will then come and tell you when you ask them utilization of your phone, what percentage are you at? So the same question can be answered in 2 ways. The person who's able to capture that data and store it in the phone will tell you, I'm able to capture the data and store it in my phone. Utilization is 100%. The person that wants to make phone calls outside with the stored numbers in the phone is unable to make those phone calls outside, will tell you utilization is at what? Is at 0, because then I'm just able to get contacts in my phone. But if you speak to me about the functionality of the phone, which is to make phone calls, I'm unable to make those phone calls. Therefore, the response you get from the second cadre is that, for me, utilization of my mobile phone to make phone calls is at 0. So when I now begin to speak about utilization from an M&E perspective as an example, like I said, we need to I add a definition to it. So I would say utilization from our perspective, right? Should be that we should be able to use the data that we collect for reporting purposes. It should be able to inform decisions. So it should be one thing for us to be able to collect it, but it should be another for us to be enabled to utilize that data to inform decision making. So that's the starting point. In our engagements as PHO, there are several aspects that affect utilization of the SMARTCARE system. The first one, which mainly affects high volume facilities, has to do with staffing. Most high volume facilities will communicate to you that they've got inadequate staffing in their facilities. Therefore, they don't have adequate staff that are able to attend to the client and also able to do what? Also able to input that data that they're capturing from the clients into the system. So for us, that's a challenge that's affecting SMARTCARE utilization. Another issue that will be affecting SMARTCARE utilization would be the networks. I think we've noted even in the networking of most of these facilities, the implementing partners or even just within the Ministry of Health and around SMARTCARE, over the last couple of years, we've prioritized the ART section of facilities. So there you most likely find that equipment is adequate as well as networking infrastructure is adequate. But when it comes to these other departments, networking infrastructure as well as equipment, ICT equipment, in most cases is inadequate to service the needs of these departments. Another area which is affecting SMARTCARE utilization is training. So we have scenarios where we've trained healthcare workers. First and foremost, when we call for these trainings, we have the same cadre that is being sent for these particular trainings. Secondly, when this cadre is being trained, they're trained with hopes that when they go back to their facilities, they are champions and they begin to mentor their fellow healthcare workers in these facilities. We've noted the lapses and the gaps with regards to that information transfer being taken back into these facilities from the cadres that have been trained during these training exercises that we conduct. Another issue that is pivotal as well is the systems reporting functionality. Like I stated, we can have all of these things at the top. Staffing needs met, networking needs met, equipment needs met, training needs met. But if the system is unable to inform us through the reports that it's able to generate, it takes us back to one. But then again, we also need to ask ourselves another question is, if all of these boxes are ticked, the system is able to adequately report, training is enough, equipment, networking, and staffing is enough, we normally face another roadblock. I'll come back and I'll say, are the facilities ready? Is there a necessary push from the leadership within these facilities? Is there a necessary push for management? Is there a necessary buy-in for management as well as healthcare workers and staff to utilize the system on a daily basis? So for me, with regards to SMARTCARE utilization, to sum it all, the problems that we're facing around this utilization are multifaceted. So the last thing that I would want to then add on, in an attempt as PHO to remedy the issue around poor SMARTCARE utilization, we took up a specific approach that was to select a few pilot sites around the province and term these sites as model sites. And in these model sites, we engage these facilities. And from the challenges that I listed, if I go through the challenges I listed one more time for them to be clear, we said staff, network, equipment, training, as well as system functionality. As an ICT department, which one of these 5 challenges are we able to tackle head on? Automatically, staffing is out of our jurisdiction, so we have no control over that particular challenge. All we can do is escalate it to higher officers for it to be dealt with. But with regards to networking, we're able to go in and improve on the network infrastructure. With regards to equipment, where and when we can come in, where we can source a tablet, we source a tablet for that model facility site. Where we can source a desktop, we source a desktop for that model facility site. So that because we understand that it's part of the cascade that eventually affects SMARTCARE utilization at the end of the day. With regards to trainings, We had trainings and emphasized on training champions so that we can have champions in these departments that are able to actively and willingly pass on this skill that they've obtained through the trainings to the rest of the cadres within the MCH, ANC, and other departments. Additionally, we've also engaged IHM with regards to the lapses or the gaps that we've noted in the system. So to give you a little bit of insight, we engaged IHM with regards to the report functionality in SMARTCARE Plus, which is something that they actively got on board on and began to rectify. During the process of them rectifying it, they have transitioned to where they're currently transitioning our facilities to Pro. And we are aware that currently in Pro, that functionality is readily available. In the SMARTCARE system, the SMARTCARE Pro system, the functionality, the complaints around report functionality have been dealt with. Additional modules around the discussion we're having today have been added into the system and are fully functional. So for instance, if I'm going to go by the definition I gave of SMARTCARE utilization earlier, which is how much data are we pulling out of the system, which is enabling us to inform decision making. For instance, if I'm going to look at the 226 facilities that we have in Osaka province, 76% of those facilities are currently being transitioned to Pro and are meant to go live any day. So going by that definition that I gave of SMARTCARE utilization and us being able to extract data from the system and use that data for reporting, if we're to migrate and go live today on SMARTCARE Pro, our SMARTCARE utilization based on that definition will go from 0 to 76%. So I hope in that explanation, I've been able to tackle quite a number of questions, and then I've also been able to hopefully highlight the challenges that we need to rectify with regards to assisting us or aiding us in improving our SMARTCARE utilization. And I think my last point, whilst I'm on this subject, would be that like I've stated, for Lusaka, for us to improve SMARTCARE utilization, and I will attest that in the model sites that we have tried some of these strategies, we've sort of been successful to a certain degree. But then I just want to put it out there to everybody that, like I've stated, we've mentioned the challenges from our experience, from our perspective, that we feel affect SMARTCARE utilization. You do not need to wait for an initiative such as ours, because this initiative was supported by CIDAS. They assisted us in conducting some of the trainings. They were on the ground with us, providing some of the mentorships. You do not need to wait sometimes as facilities for some of these initiatives to be started at a much higher level or wait for an implementing partner to come in and support you. Like we've stated, these are things that we sometimes can deem as low-lying fruit. We have the expertise within our provinces, within our districts, within our facilities to improve on our networks. We have capacity within our facility, within amongst our healthcare workers who have been exposed to SMARTCARE trainings, who are actually champions in SMARTCARE. We now need to begin to home in on those skills that we have within our facilities and ask these cadres to then pass on this knowledge to the other healthcare workers that they have within our facilities. Lastly, one key factor which is affecting utilization, like I stated, from an M&E perspective on how we're going to measure utilization, has been system reporting functionality. And like I've stated, this is an aspect that has been tackled by the SMARTCARE Pro system, which is currently being rolled out. So I'll leave everybody in this meeting with a question. If all these things are ticked off, and the last one being the systems reporting functionality, which has been tackled by IHM, and I can say that 90% resolution has been resolved to a degree of 90%. At what state are we at as healthcare workers? At what state are we at as facilities that when all these things are ticked, will we be able to then move SMARTCARE utilization from 0% to 100%? So I'm speaking about our preparedness and our readiness with regards to networks, equipment, training, and staffing. Thank you. That's my submission.
Thank you so much, Kapupa. That was a very detailed submission. Just check through the chat box. I think Harry wants you to just list those challenges in the chat box. But thank you so much for your detailed analysis. The other two colleagues have dropped their hands, so I'll just allow Richard Stumbeko to just give your comment or question in under a minute so that we can give chance to Dr. Wantula to just weigh in as well as one of the experts. Richard?
Afternoon. This is Richard from Shangombo. I just want some clarity on, I heard a statement like sorry? So I heard a statement like if the facility has got both SMARTCARE and paper-based, we need to prioritize SMARTCARE. So in the light of being E-last, E-first, I just want clarity on that statement. Do we use both, or we just open the file and then proceed to using the SMARTCARE for subsequent visits?
Thank you so much, Richard. That one will be tackled. Mporokoso, Hospital Information Officer. I think that's William. You've also raised your hand. You can give your question or submission in under a minute.
Thank you so very much, Chair. I wanted to make a comment based on what my colleague has said, where there is a paper-based and SMARTCARE Pro. Then the other question I wanted to make was how do we go about the admissions under MCH, especially under labor and delivery in SMARTCARE Pro? I submit because when we admit our patients, we are unable to view them under admissions or those that are in labor. I submit, Chair. Thank you.
Thank you so much, William. Ernesto from Charleston Level 1. Is Charleston a Level 1, Ernesto?
I think it's a zonal hospital.
Right.
Good afternoon, Doc.
Afternoon.
Yes, thank you so much for the opportunity. And very good submission indeed from Mr. Kapupa. Mine is being one of the SMARTCARE trainers. I think from what I've noticed is that healthcare workers should also take it up and understand that SMARTCARE program is not really just an idea that someone came up with, but it's an MoH program that is there to really improve the healthcare system in Zambia. So what I've noticed is that when we go for this training or to orient people, there are some resistance, more especially when it comes to some of our healthcare workers. They seem not to be of the idea to change from E-last to E-first. So there is very, very good response, and we are working very well in making sure that people are oriented adequately to SMARTCARE services. But some, indeed, there's always that small resistance that is there. So if we can also just make sure that our health workers understand that it's just ideal for an individual to also know how to use the SMARTCARE Plus or SMARTCARE Pro, that will actually be more of help. Thank you so much.
Thank you, Ernesto, for your submission. Very well noted and very timely. Dr. Wantula, you can just give us some of your final thoughts around this presentation and around SMARTCARE utilization in general in MCH. Dr. Wantula.
Thanks a lot, Network. Thanks, everybody. Please confirm to get me.
Yes, we can get you. You have about 2 to 3 minutes.
All right, thanks. Very interesting discussions. I think a lot of what I was really thinking about has been tackled, but I really wanted to just, I guess, summarize my point using what I think Kapupa as well elaborated analogy of what SMARTCARE utilization is. So really, aside from the fact that the system helps us in terms of improving our reporting and improving how we do patient care, it also helps us at a high level in terms of planning. Chimuka did touch on these things, planning, but there's also critical issues around, like certain things like estimates, for example, like we want to estimate how many children are living with HIV, for example. These data come from the same data that are coming to MCH. feeding to that. So if the MCH data is bad, then we'll have a bad output from CLHIV, and then we have these 61,000 plus children that are living with HIV that most of them we can't locate, based on the fact that data is not correct, so to say. So it's got such huge impact, not only in patient care, but also in terms of how we think as programmers and public health specialists. And so back to the utilization. So really, I think, and we've had several visits sometimes with Kapupa and thinking around this thing. Last time we were in Lusaka, really around, okay, so now you are, and thank you for IHM that are very responsive to getting these reports out now. Now that you have reports, how can you use this system, as a to sort of as a quality control system for the cascade of care? So how do you know that you're actually utilizing the system to the optimal best? So today you had 10 clients that came in MCH. Does the MCH report pull out 10 clients that you saw in SMARTCARE? Then you can say, we know we had 10 clients, but SMARTCARE only has 5. So our utilization therefore is at 50% just on this parameter. Or you tested XY from the 10 that came, you tested 25, but the system says you only tested 2. Then you sort of start having these sort of quality control points where you can now, as a facility, as a district, and ultimately as a province and as a nation, you can pick out pain points in how to improve the system. But there's no way we can improve this system if we don't use it and get to this point so we can actually identify these gaps, be able to now institute quality control measures. So the most important thing is utilize the system. Are you not able to enter 5 of the 10 because of staffing? Document that. Now that's the issue, because now we have a system that can give us what we want, but the root cause of why we're not getting where we want to be is because we have staffing levels. So how to sort that out? Sometimes staffing levels are beyond what the facility can do. But then how do you optimize your flow so that the existing machines can be utilized at the pain point within the flow of your patients, and not every single provider having a machine? So yeah, so the issue around utility really is very cardinal, and Kapupa, I think I'll call you again and just pick your brain on how you come up with this system. But it's really well thought out, and how at every single point you can measure what you mean by utility, and that right now we are now at a point that we can actually use measure utility versus on utilizing system functionality, whether or not it can give us apples and apples when we're trying to measure attendance. Is attendance the same thing? Is testing the same thing? Is HIV care treatment the same thing, and so on and so forth? So at the site level, I think that's how we start thinking around how do we improve utility of this. It's really about not just throwing in data into a system, but making it useful for ourselves to make decisions at site level, but also making decisions at national level. So I think I'll pause there, bearing in mind that most of the things that are pertinent to this issue have been discussed. Thanks for the opportunity.
Thank you so much, Dr. Wantula, and indeed, thank you for your encouragement, and thank you for your comment. Dear colleagues, we have run out of time. It's 4 o'clock, so allow me to just call Dr. Sam to just give his final thought in 1 minute, and then we'll also allow Chimuka to just give his final thought in 1 minute as well. Dr. Msariri, just in 1 minute, just give us your final thought.
All right. Thank you so much, Dr. Muhuma and everyone. So I think from our end, very happy to get the feedback that has come in. I think, as my other colleague from LPHO mentioned, there is definitely a cascade when it comes to utilization of the modules in MCH. Suffice to say, obviously, with some facilities that maybe have challenges with network equipment, there are other facilities which have all of these, but still are not using the MCH module. So there, what really is the challenge? How do we manage those? And I also feel very strongly that if we could build from those model sites and drive that utility from there, because as with every system and its implementation, it's very difficult to get to 100% satisfaction in terms of all the 5 parameters that were outlined. So I also do think that for those facilities that have no or none of these issues, which are the majority, we still have very low utilization. They're still under 4%. So for me, I think there's a lot of investment that we also need to do from a programmatic perspective, where to the same degree as the ART program has been able to invest in terms of just building awareness, building the demand, driving that uptake, I think we also need to collaborate and work together in a similar fashion for us to increase utilization under MCH. Those were my contributions. Back to you, Doc.
Thank you so much, Sam. Thank you for taking the time to be able to participate in this discussion. Chimuka, your final thoughts in under a minute.
Okay, so thank you, Doc, and also thanks for people for joining. I think I'll borrow what Dr. Sichembe said, that I think one thing we need to bear in mind that there will never be a system which will be perfect. Every system will have 1 or 2 challenges, and it's us, the people, who make systems better. So the only way we can make these systems better is through system utilization. So the more we use the system, the more we'll be able to identify challenges which are there, and it's through those challenges that we've identified. That's why IHM, actually, ideally, IHM, their role is to be able to attend to certain issues which would have found that they're impediment for us to be able to make use of our SMARTCARE. I think that should be one of their challenges. That should be one of their role in this system. So that as we implement, let's identify areas where IHM will be able to make our work easier. But we only be able to do that if we make use of our system. I also just want to make one last comment concerning the paper-based arrangement. So, like I indicated, it's policy that paper-based electronic system takes precedence over paper-based. So what I meant when I said paper-based, that when I talk of paper-based, I meant the registers. Then when we talk of the electronic system, I know you have got the 3 types. You have got the eLast, the eFirst, and eFirst. So the first thing I was trying to say is that if you have got SMARTCARE, government and through the Ministry of Health is saying that you cannot be using SMARTCARE and a register. So register should not be used. We should concentrate on SMARTCARE. Now, under SMARTCARE, depending on the capabilities and also other factors, others may be eLast, others may be eFirst, and others may be eLast. But we are saying, let's not have a register and also SMARTCARE. I submit, Doc.
Thank you so much, Chimuka. And dear colleagues, I think the presentation is a timely presentation. We know that as a country, as a ministry, we're rolling out SMARTCARE Pro, and that's where we want to go. You heard the good things about SMARTCARE Pro. Some of you have had the privilege to be able to use them. All those using SMARTCARE Legacy, SMARTCARE Plus will be transitioned to Pro. I know IHM has a really big goal to be able to transition as many facilities as possible so that it's countrywide. I know colleagues have expressed certain reservations. Why is it only in urban centers? Why not in rural centers? Connectivity issues and power outages. But there's good news on the horizon. There are power backups that are coming through. One comment talked about power backup only in ART, but there are things that are happening in the background to make sure that all facilities, health facilities, have power at all times. Okay, and in terms of the networking, some of you may have heard of the government-wide area network, and some of you have seen that government has actually deployed Starlink in facilities where we can be able to leverage on this, because we know that when there's power outage, we might not have network. So all these challenges, dear colleagues, are being dealt with. And just as a closing, we're looking at SMARTCARE utilization in MCH. The didactic presentation was done by Chimuka he's the Strategic Information Officer from the Ministry of Health. We had Dr. Sam Msariri from IHM, Dr. Wantula Sichembe from the CDC Zambia, and Mr. Kapupa Chisenga, who were helping us with as panel of experts and giving some expert recommendations. In the hub with me, I have Prudence Mulambia, who's the Health System Strengthening Nurse from Matero Sub-District under Lusaka Provincial Health Office. Abinio Facilitator, Malilwe Muhuma, from Chawama, Level 1 Hospital. So thank you for attending. The participation was really great. The chat box was really busy. We couldn't get through to all the comments, but we thank you for this. And we will lobby that we have more of such sessions, and I hope, Chimuka, you'll be available, and not only for MCH, but for the other places as well, OPD, TB, and all the other modules, so that because we are rolling out SMARTCARE in all the facilities, so I think it's timely that we should be able to discuss these issues on this platform. So dear colleagues, once again, thank you so much. We apologize for overshooting on time. Thank you for attending. We wish you a very good rest of the week. Thank you. Bye-bye.
Thank you.
Bye.
And thank you so much. Bye-bye.
Thank you so much.
Bye.
Thank you for the insightful presentation. Thank you so much.
Thank you. Bye-bye.
Okay.